our bodies and our hormone levels really do start changing probably somewhere in our mid to late 30s. And I think many of my patients used to think of menopause as sort of a light switch on and off, but instead it's really a several decades transition.
Hi, I'm Dr. Carrie Mazzuto, board-certified internal medicine physician, functional medicine expert, and VP of clinical operations here at Lifeforce. I am thrilled today to be joined by Dr. Kathryn Rexrode. Now, I'm going to give you a little bio. She's got a lot that she's accomplished in her career. So Dr. Rexrode is the chief of the Division of Women's Health in the Department of Medicine at Brigham and Women's Hospital, and an associate professor of medicine at Harvard Medical School. She has broad and deep research experience in women's health with a focus on the biochemical, genetic, and lifestyle risk factors of cardiovascular disease in women. She also leads multiple grants from the NIH and is the author of more than 250 research publications. Dr. Rexrode also leads the Office of Women's Careers and the Center for Diversity and Inclusion at BWH, where she works to advance gender equality, diversity, and inclusion. And on top of all of that, she still practices as a primary care physician to rave reviews from all of her patients. And we are so thrilled to be joined today by Dr. Kathryn Rexrode. Welcome.
Really a pleasure to be here. Thank you so much.
Well, with everything that you've accomplished and all that you're doing in your line of work, what made you want to join up with Lifeforce?
Well, as I look at programs that are focused on optimizing health, very few of them really seem to take a female-specific view and to really focus on how performance optimization and health and well-being optimization might be different for women. And so that's really been the motivating factor of my research and clinical care. And I was really excited about Lifeforce's vision and their commitment to thinking about what might be different for women.
Oh, that's so wonderful. And I'll be honest, that's exactly my first question for you was, what are aspects of performance or longevity or preventative care? What are areas that you see get overlooked in the research, that they tend to do studies on men, but there's no data on women? What are some areas that are most prevalent that you've seen?
Well, that was really the motivating factor for my own research career. I don't think I expected to go into research, but the lack of data in a number of areas really got me hot and bothered enough that I wanted to be a part of that solution. I think, there was a time when the focus of research in women and the health of women was really what we sometimes call bikini medicine. So it was about breast health and it was about GYN health and reproductive health. And then it was assumed that pretty much everything else must be the same for men and women, and we could just extrapolate. And fortunately, starting in the 1990s, the National Institutes of Health did recognize that we really needed representation of women in clinical trials to understand how their responses to treatment might be the same or different than men. But often, there's still a mismatch between the number or the percentage of women that might have a particular disease and their representation in clinical trials. So for instance, I do a lot of research on stroke, and in fact, more women than men die every year of stroke. And women make up a really large percentage of our stroke survivors in our population. And part of that is because women live longer. We do have a bit of a survival advantage. But in research studies of stroke, often there are more men than women. Well, why would that happen? Because some of those studies have age limits that make it such that at younger ages, perhaps more of the patients are men than women. And so we end up with data that doesn't really fit the group where we have the most clinical need or answering the questions that I, as a physician, might have for my 80-year-old patient that has a stroke. So those are some of the examples where we have gaps in data. And really it can be in any domain, thinking about what's different in women? How might the disease manifest differently? Are there different risk factors? Are there female-specific risk factors? A lot of my own research has looked at things like the timing of menopause and women who have certain complications during pregnancy and how that's related to cardiovascular long-term risk. But many of the studies didn't ask questions about that. So we really have gaps in our knowledge about those topics. So thinking both about female-specific risk factors, how the disease might be different in women, whether there might be differences in the treatment of women, all of those things are really still areas where most of the time we have incomplete knowledge. And I would argue that one of the first elements in precision medicine ought to be thinking about our sex and gender, because they affect so much in our lives. So there's really so much more research to be done.
Wow, that's fascinating, thinking through all of the different reasons why, these things aren't studied in women. And between the age factors, I never thought about that, with the increased longevity for women having strokes beyond the time that they're doing the studies for. So just one of many reasons. Wow. Well, when you have so much of the data that is talking about these issues in men, it tends to be the thing that's most prevalent in the news cycles and, that people are thinking about. I've very often found that because of that, women don't necessarily prioritize their own health because they don't hear about all of the things that they should be concerned about. What are some other reasons that you feel that women aren't prioritizing or struggle to prioritize their own health?
I agree. I do think that women often have a difficult time prioritizing their health. And for many of my patients, pregnancy was the time they prioritized their health most. And that was because they were responsible for nurturing another human being. And then after that, and this is due to our culture, much more our gender than our sex, women are most often the caregivers and caretakers of their families, and very often prioritize the health and well-being of other people more than their own. So often that's a negotiation that I have to have with a patient to think about how can they really focus on their own health, because ultimately they're not going to be a very good caretaker if their own health isn't secure. It's so important to be setting that experience as a role model for perhaps their children, of taking care of their own health so they can take care of others, sort of putting on that oxygen mask for yourself before you take care of others. But I think that, there are so many different stressors going on that I find often women have a hard time prioritizing that for themselves.
That's so true. When women do finally come to you and say that they're having issues, especially during maybe the more transitional decades in their late 30s, 40s, 50s, when their bodies are going through so many changes, what are some of the things that they most often complain about or are concerned about as they're aging?
So as you pointed out, our bodies and our hormone levels really do start changing probably somewhere in our mid to late 30s. And that process until things stabilize often goes into the mid 50s or even later. And I think many of my patients used to think of menopause as sort of a light switch on and off, but instead it's really a several decades transition, and one which can often be sort of forwards and backwards and up and down. It's not just a linear process, and it's different in each woman. And it's hard to predict exactly how it's going to be for any particular woman. So what I tend to see in the earlier years in that transition, in the mid to late 30s and early to mid 40s, are maybe subtle changes in a menstrual cycle, but also changes in sleep and in mood, sometimes hot flashes or waking up hot at night right before their menstrual cycle, because that's when estrogen levels are at their lowest. And so those can be some of the most common symptoms early on. We're all familiar with hot flashes that tend to really spike up closer to the menopause and actually even after women's periods have stopped. But again, that can be a sort of a stop and go cycle. Sometimes women skip a couple of months of a period in their 40s or early 50s, and they have a lot of symptoms, and then they'll get a couple of normal cycles and not have as many symptoms. For other women, the sleep disruption can be the main factor, and that can obviously lead to fatigue and brain fog, and difficulty coping, can relate to other mood symptoms, depression and anxiety, which can also contribute to sleep, but sleep deprivation in and of itself can have a big impact. So there's really a myriad of symptoms throughout that transition, and also so many different experiences for each individual about when they might have symptoms or what kinds of symptoms they will have. I'm not very good at predicting who's going to have a lot of symptoms versus not. And I try to be very transparent and say, I can't predict. I can tell you what you might experience. And then when you do start to experience it, we can talk about it.
Yeah, that's such a good point that it really is different for every woman. And it's probably one of the things that is very unique to women too, just such a wide range of symptoms that you can experience as your body is going through really significant hormone changes. So when you have these changes, like you said, it's normal, it's natural to go through these changes. What is your approach to support women that are coming to you that are experiencing changes that lead to symptoms that are impacting their quality of life or their feeling of well-being?
So you're absolutely right. Some women go through that transition and hormonal changes and don't have a lot of symptoms, and then we don't have to do so very much. But for some, it can be incredibly disruptive and really, as you point out, contribute to their well-being. And so then we have to think about what kind of hormonal changes are contributing to their symptoms. The decline in estrogen is really the hallmark of this change throughout, the perimenopause and transition to menopause, although other hormones also change. And so thinking about how estrogen and other hormones might be related to symptoms. And then for the person who is having symptoms, treating with hormones can be really effective and sometimes life-changing.
Yeah, absolutely. And then what about some lifestyle approaches? Do things like sleep and diet and exercise, do those impact how a woman transitions through this time?
Oh, well, as a researcher, I don't know that I can prove that changing these factors will make it better or worse. But I can say that taking care of overall health while you're going through other changes in your body is sure to have an impact. So to the degree that you can focus on sleep, knowing there might be disruption from hormones, but making certain that you have the opportunity to get enough sleep and that you're exercising what we call good sleep hygiene, making certain there's enough time, winding down before bed, avoiding screens and other agitating kinds of things. So improving sort of the general circumstances of sleep won't change the hormonal side, but should contribute to better sleep overall. Physical activity has definitely been shown to improve some of the weight gain that sometimes is experienced around menopause, and for many women really contributes to their well-being, improving mood, reducing anxiety. And so that is something I would always advocate for improving health overall. And then diet is always important. I encourage patients to, eat whole foods, fruits and vegetables, and to avoid processed foods as much as possible. As estrogen levels decline, cholesterol levels tend to go up. So it is a time where really thinking about sort of a heart healthy diet is particularly important. And so all of those things can definitely contribute to improved health and well-being during a time when there are some other things that are changing, but those recommendations stay pretty much constant.
Fantastic. And you touched on heart health for women as they are aging and going through increasing the risk for cardiovascular disease. I've heard a lot about omegas supporting men's cardiovascular health in the data. Does it have the same benefit and impact for women? Do you recommend being on omegas or other things that can help support women's cardiovascular health and lower their risk?
So I would say that might be an area where we have some gaps in the data. There was a large study of vitamin D that included both men and women for cardiovascular health and didn't show clear differences between men and women. Didn't absolutely prove that everybody should take it either. And those women were somewhat older, so not in this earlier transition group. Certainly trying to get as many omega-3s from diet as possible, and often that really is difficult. So a supplement can be helpful. So I think that's an area where we don't have a sex-specific recommendation, but I do think can be very helpful.
Okay, great. And you mentioned vitamin D, and obviously bone health is another big issue that we know impacts women as they go through the perimenopausal and menopausal timeframe. Is checking vitamin D's levels something that you recommend to make sure that they're getting adequate vitamin D, especially when they're younger, before they reach that point, so they have strong bones by the time you go through menopause?
So absolutely building bone before menopause and being sure that you're getting enough vitamin D and calcium before menopause so you don't steal from our bone bank, as it were, to make up for a lack in diet is really important. So focusing on getting enough calcium in one's diet and or from a calcium supplement, as well as enough vitamin D, which tends to be much harder to get from diet, so often requires a supplement, is something that I do discuss with my patients. And a vitamin D level can be helpful, particularly for people who really avoid the sun or, might be otherwise at risk of having lower levels. Also to help guide what's the right amount of vitamin D for that person's metabolism.
Great. Yeah, definitely. We've seen more and more people be super sun conscious. And, even when they are living in places that they could have access to the sun, they're not getting out as much. So I love being able to give them a number to follow and to make sure that we're appropriately, and that's the key, right? Appropriately supplementing when needed.
Yeah.
How about, you mentioned some anxiety, sleep disturbances, all being part of hormonal transition times. Something that I've personally recommended a lot is using magnesium to help support those. Is that something that you've used in your practice and recommend as well?
I think magnesium can be really helpful, often for sleep and for mood. I would most often think about it at nighttime for my patients. And so that is a supplement that often can be helpful. I'm not sure that I have seen it specifically, whether it treats any specific, sort of menopausal or hormonal symptoms, but as you say, they're so commonly associated that is something that can be very helpful.
Yeah, another natural support to help mitigate some of those or support people through those symptoms. Well, fantastic. Dr. Rexrode, you've given a lot of wonderful pearls of wisdom here. Is there anything else that you would like to share? I always ask people, what's the piece of advice that you wish you could tell everybody if they would only ask you for it? Is there anything that comes to mind?
Well, I think we go back to what we started with, which is prioritize your own health. Think about treating yourself as you would treat, the other people around you. And it's never too late to start prioritizing your health. And especially during this time of transition through the 30s, 40s, and 50s, it's really essential.
Oh, that's so great. What a fantastic reminder and a great note to end on. Dr. Rexrode, thank you so much for your time today. I thoroughly enjoyed getting to speak with you.
It's really a pleasure talking with you, Dr. Masuda.